Assalamualaikum and hi everyone! Do you know what is muscular dystrophy is all about? Let's learn it together. So, what is muscular dystrophy? Muscular dystrophy is an inherited disorder that causes progressive weakness and degeneration of the skeletal muscles that control movement. This happens due to abnormal genes which mutations interfering with the production of proteins that are required to produce healthy muscle. The protein is called dystrophin. The absence of dystrophin can cause problems with muscle coordination, walking, and swallowing. There are many kinds of muscular dystrophy. Some kinds of muscular dystrophy begin in childhood or early adolescence, whereas others may not appear until middle age or later. However, most diagnoses occur in childhood, mostly in young boys rather than girls. The disorders differ in terms of muscular weakening distribution and severity, onset, age, rate of progression, and inheritance pattern. Certain kinds of muscular dystrophy also affect heart muscle. There is no cure for muscular dystrophy, but medications and therapy can help manage symptoms and slow the course of the disease.
And now we are going into pathophysiology for muscular dystrophy. So the first one is the elements. So there are multiple proteins that are involved in the complex interaction of the muscle membrane and extracellular environment. And there are also important elements for sarcolemma stability, which are dystrophin and also dystrophin-associated glycoproteins DAGs. So what is dystrophin? So dystrophin is a gene located in the short arm of chromosome X and its functioning as a maintainer of muscles, membrane integrity and stability. Dystrophin will associate with actin at its N-terminus and the DAG complex at the C-terminus, and both of them will form a stable complex. And that stable complex is the one that will interact with extracellular matrix. But what happens when someone lacks dystrophin? So the lack of dystrophin will cause a leakage of intracellular components, resulting in a high level of creatine phosphokinase CPK, and that is what happened in Duchenne muscular dystrophy (DMD). For the less active dystrophin, they may also cause the leakage of intracellular components, even though they are still functioning as a sarcolemma anchor, but not so effective as a fully functional dystrophin, because they still allow some leakage happen. And that is what happened in Becker muscular dystrophy. Now I'm going to tell you guys a bit about what causes the Duchenne muscular dystrophy and Becker muscular dystrophy. So in both Duchenne MD and Becker MD, the muscle cell unit is gradually dies and macrophages invade, even though this condition is not reported as an immunological mediated. This is because class 1 human leukocytes antigens HLA are found in the membrane dystrophic muscles, and this feature makes these muscles more susceptible to T-cell mediated attacks. Lastly, I'm going to tell you guys a bit what causes the other type of muscular dystrophy. The causes of other types of MDs are because of the alteration in the coding of one of the DAG complex protein. Gene defects in the DAG complex will lead to alterations in cellular permeability. But other associated effects can also occur because of the slightly different mechanism of action and the location of the genes, like ocular and limb-girdle dystrophies.
The most common form of muscular dystrophy is Duchenne muscular dystrophy. It is caused by the absence of dystrophin. People with this type of muscular dystrophy will have muscle weakness, and they may have breathing issues and or heart issues. This type of muscular dystrophy primarily affects boys. Becker muscular dystrophy is very similar to but less severe than Duchenne. It has faulty or not enough dystrophin. People with Becker muscular dystrophy will have muscle weakness. Becker muscular dystrophy only affects males. Next, for facioscapulohumeral muscular dystrophy, that also known as Landaudet-Dejorain disease, usually begins in the teenage years. It causes progressive weakness in muscles of the face, arms, legs, and around the shoulders and chest. It progresses slowly and can vary in symptoms from mild to disabling. Next, myotonic muscular dystrophy, which is the most typical adult type of the disorder in their 20s and 30 years old. It is characterized by stiffening and continuous spasms of muscles. For congenital muscular dystrophy, this type affects boys and girls and is apparent at birth or early during infancy, age 2, when parents begin to notice that Their child's motor functions and muscle control are not developing as they should. For limb girdle muscular dystrophy, hip and shoulder muscles are usually affected first. It may also occur in your legs and neck. Onset usually begins in childhood or the teenage years. Limb girdle muscular dystrophy affects both males and females. Most people with this form of muscular dystrophy are disabled by age 20. However, many have a normal life expectancy. For oculopharyngeal muscular dystrophy or PMD, it is categorized as weakness in your facial, neck, and shoulder muscles. PMD occurs in both men and women. For distal muscular dystrophy, it is called as distal myopathy. It affects muscles in forearms, hands, calves, and feet, also affect respiratory system and heart muscles. Most people, both male and female, are diagnosed with distal muscular dystrophy between the ages of 40 and 60. And next, for MRI-derived muscular dystrophy, it is categorized as muscle weakening in upper arms and lower legs. It affects more boys than girls that usually begins in childhood. And it hurts me to say that more individuals die in mid-adulthood from heart or lung failure. But wait, how to know a person is having muscular dystrophy? Now let's figure it out. Investigation will be started with a medical history and physical examination on the patient. After that, some tests stated here are recommended to be done on patients. We may investigate muscular dystrophy with blood tests. People with muscular dystrophy has markers of muscle damage such as creatine kinase CK and aldolase, which are proteins in blood. Muscular dystrophy patients typically have these proteins above normal level, especially in earlier stages of disease. In a person who hasn't had a traumatic injury, high blood levels of CK suggest a muscle disease. For electromyography, a small needle called an electrode is inserted into the muscle tissue to be tested. Electrical activity in muscles are measured by the electrode as they are at rest and as they contract during movement. Changes in the pattern of electrical activity can confirm a muscle disease. It is often done at the same time as a similar test that called as a nerve conduction study. This procedure is done with electrodes placed on the skin. It measures electrical activity in nerve cells. Doing both procedures can be useful for determining whether muscle weakness is caused by problems with nerves or with muscles. Next, MRI, magnetic resonance imaging. It is a technique that uses a magnetic field and radio waves to produce detailed image of the inside of the body. People with muscular dystrophy typically have a higher than normal concentration of fat in their muscles. MRIs help clinicians understand which muscle is affected most by muscular dystrophy and can inform the choice of a suitable muscle for a biopsy if needed. For muscle biopsy, where a small piece of muscle tissue can be removed through an incision or with a hollow needle. Biopsies may be collected either with a needle inserted through the skin or by making a cut through the skin that depends on the specific muscle and the amount of tissue needed. Analysis of the tissue sample can distinguish muscular dystrophies from other muscle disease. For a 6-minute walk test, it is a measure to know how far a person is able to walk in 6 minutes on a flat and hard surface. This test is used to assess physical function and exercise capacity in individuals who are able to walk and may be useful for monitoring changes in function over time. For genetic testing, clinician will take the blood sample of client and the blood sample can be examined for mutation in some of the genes that cause types of muscular dystrophy. While for heart monitoring tests, which are electrocardiography and echocardiogram, these tests are used to check heart function, especially in people diagnosed with myotonic muscular dystrophy. Lastly, lung monitoring tests are used to check lung function. Alright, now we move to signs and symptoms of muscular dystrophy. The main indication of muscular dystrophy is progressive muscle weakness. Depending on the kind of muscular dystrophy, certain signs and symptoms appear at different ages and in different muscle groups. Signs and symptoms of Duchenne and Becker muscular dystrophy quite similar, but Becker tends to be milder and progress more slowly than Duchenne muscular dystrophy. People with this type of muscular dystrophy may experience muscle pain and stiffness, walking on the toes, difficulty rising from a lying or sitting position, and frequent falls. If you have myotonic muscular dystrophy, then you may experience drooping eyelids, thin face and haggard look, swan-like neck and early baldness in the front area of scalp, poor vision, increased sweating, difficulty swallowing. Besides, for facioscapulohumeral muscular dystrophy, you may experience difficulty chewing or swallowing, a crooked appearance of mouth, slanted shoulders, and your shoulder blades might stick out like wings when arms are raised. Next, people with congenital muscular dystrophy will experience muscle weakness, poor motor control, scoliosis, inability to sit or stand without support, speech problems, foot deformities, and vision problems. Moreover, if you have this form of muscular dystrophy, which is oculopharyngeal muscular dystrophy, you will experience drooping eyelids, voice changes, difficulty walking, vision problems, heart problems, and also trouble swallowing. Besides, if you have this limb-girdle muscular dystrophy, you will experience difficulty lifting the front part of the foot, and so you might trip frequently. Hard to get up out of a chair, difficulty walking up and down stairs, and difficult to carry heavy items. You may stumble and fall more easily. Meanwhile, for distal muscular dystrophy, people will lose fine motor skills and difficulty walking. Lastly, for emery reverse muscular dystrophy, signs and symptoms that you will develop are breathing problems, shortening of the muscles in spine, neck, ankles, knees, and elbows, upper arm and lower leg muscles weakness, and heart problems.
Now, we are going to discuss about the medical management for muscular dystrophy. The first one is corticosteroid management. Corticosteroids are the mainstay of pharmacologic treatment since they are helpful in slowing down the progression of muscular dystrophy. These types of drugs should be started before further significant physical impairment occurs. Prednisone, a corticosteroid medication, is beneficial, especially in the treatment of Duchenne muscular dystrophy patients. So how does corticosteroids work? The positive benefits were previously considered to be mediated by the inhibition of cytotoxic T cell production from the necrotic muscles. There was evidence of improvement in timed muscle function, such as the time it took to climb 4 stairs, with 43% faster with prednisone, and in pulmonary function. Corticosteroids also reduce the risk of scoliosis and delay the loss of ambulation in patients with Duchenne muscular dystrophy. The second one is rehabilitation management. A physical therapy program is usually part of the treatment to allow greater motion in the joint and to prevent contractures and scoliosis. A home program is recommended to dystrophic patients where stretching exercises for the lower extremities can be performed twice a day on a firm surface to minimize contractures by keeping tendons from shortening prematurely. Engaging in regular therapy sessions on the gait training and transfer techniques are crucial to improve stability as well as balance. Next, the use of adaptive equipment to maintain the patient's ambulatory status. Braces or orthoses can be used to support the ankles and feet. Regular standing improves posture and circulation, but it might be challenging for dystrophic patients. Thus, standing frames can make standing more comfortable. While physical therapy emphasizes mobility and strengthening of large muscle groups, occupational therapy focuses on occupations and function. Occupational therapy can help with tasks for work, recreation, or daily living activities, such as dressing or using a computer. Now moving on to the next management, which is orthopedic management. Surgical intervention on the foot is necessary to help improve varus positioning, and surgical intervention on the Achilles tendon to improve dorsiflexion range will be sufficient to improve gait in patients who have clinically significant ankle contracture but good quadriceps and hip extensor strength. Surgery may be of the greatest benefit to children who are in the ambulatory stage, but it is being recommended less frequently than in the past. Next is bone health and osteoporosis management. The presence of bone fragility in muscular dystrophy is well documented historically, and it is thought to be caused by limited mobility, decreased vitamin D absorption, and also lack of sun exposure. Patients with Duchenne muscular dystrophy who are treated with glucocorticoids frequently are prone to develop osteoporosis, which manifests itself as low trauma vertebral or long bone fractures. As a result, the following treatments may be used.
The first one is calcium and vitamin D supplementation. The second one is the vibration therapy. This kind of therapy is intended to improve muscle strength, which has a positive effect on bone density. The third one is bisphosphonates. Bisphosphonates typically used in pediatric patients include oral alendronate, intravenous palmidronate, and zoledronic acid, where these agents have been shown to improve bone mineral density as well as ease fracture-induced back pain. Next is psychosocial management. The medical care of a patient who has muscular dystrophy is not complete without support for their psychosocial well-being. Lack of dystrophy on brain development and functioning, social and emotional factors as well as glucocorticoids treatment can all play a part in their psychosocial health. Thus, pharmacological interventions are included for psychosocial management. For example, selective serotonin reuptake inhibitors can be used for depression, anxiety, and obsessive-compulsive disorder. Next is mood stabilizers for aggression, anger, or emotional dysregulation. In terms of psychotherapy, individual therapy is recommended for internalizing behaviors such as low self-esteem and depression, anxiety, obsessive-compulsive disorder, adjustment, and coping difficulties. Meanwhile, group therapy is recommended for social deficits, and family therapy is suggested when dealing with adjustment and coping difficulties, as well as parent-child conflict. Now, let's have a look at respiratory management. The use of assisted cough techniques can help keep the bronchiole free of secretions. Cough techniques are necessary for patients with baseline peak cough flow that less than 270 liters per minute. Assisted ventilation, which is the non-invasive device, can be used where the person receives air under pressure through a mask, nosepiece, or mouthpiece. Non-invasive ventilation is usually required only part-time and often only during sleep. The last one is cardiac management. Treatment with an ACE inhibitor or angiotensin receptor blocker for boys with the muscular dystrophy should begin by the age of 10 years, but preferably earlier. Cardiac transplantation is an option in patients with Becker muscular dystrophy who have severe dilated cardiomyopathy and limited or no clinical evidence of skeletal muscle disease.
Now, let's move on to multidisciplinary team members involved and their roles. Muscular Dystrophy and Primary Care Provider (PCP). PCP is considered as the medical home since he or she will manage all necessary treatment and surveillance as well as collaborating with the neuromuscular team. The first multidisciplinary team members that we will be talking about is Care Coordinator. The Care Coordinator serves as the center of the neuromuscular team. Nurses, nurse practitioners, genetic counselors, and other professionals may serve as coordinators. This individual will coordinate the patient's care in collaboration with the neuromuscular specialist and the other members of the neuromuscular team. Further, the Care Coordinator will facilitate communication between the patient, NM team, and PCP. Additionally, they will also serve as the point person for inquiries or concerns between visits. So indeed, the Care Coordinator is the NM team's glue. Now let's move on to neuromuscular care. The neuromuscular specialist, NMS, will lead the neuromuscular team. In case of muscular dystrophy, the NMS will manage musculoskeletal issues. In addition to regular evaluations, testing should be performed to assess strength and function to decide if interventions are needed. NMS will manage the steroids medication and monitor the side effects if the patient decides to use them. NMS should be seen every 6 to 12 months after diagnosis. Next, endocrinologists. Endocrinologists treat hormone-related issues such as hormones that regulate growth, puberty, and bone health. Hormone and bone complications might arise from steroid usage in muscular dystrophy. Most persons with muscular dystrophy that use steroids will need to consult an endocrinologist at some point. Moving on to genetic counselor. A genetic counselor can explain the causes, symptoms, and progression of muscular dystrophy.
They may also assist the patient's mother and other female relatives to get carrier testing. The genetic counselor may also help people process emotions and address family issues. Let's carry on with occupational therapies. Occupational therapists or OTs help patients find or develop ways to participate in the activities they want and need to do. OTs can help people with muscular dystrophy find and use adaptive equipment. An OT familiar with the needs of patients with muscular dystrophy can assist with tasks related to work, recreation, or daily living such as driving, racing, or using a computer. And OTs can also help plan adaptations for home, school, and workplace. Physiotherapists. A physiotherapist or PT can be very helpful right from the start. Physiotherapists monitor the spinal, musculoskeletal, and respiratory functions as well as supervise hydrobase or water therapy and also active and passive stretching. They will also measure muscular strength, function, and range of motion. Muscular dystrophy patients should see a PT every 4 to 6 months. Psychologists, neuropsychologists, or psychiatrists. Psychologists and psychiatrists help detect and treat any mental disorders that patients may have. Neuropsychologists are psychologists who specialize in the areas of cognition and evaluating learning, cognition and behavior with an underlying neurologic diagnosis, for example, learning difficulties. Muscular dystrophy is a difficult diagnosis to manage and the family may face high levels of stress and anxiety. Therapeutic treatment may be highly beneficial. This is an area of life that should never be ignored. Lastly, dentists. Tooth decay and plaque accumulation may worsen when jaw muscles grow weaker. Other dental symptoms of muscular dystrophy include a widening of the jaw and gaps between the teeth. The patient should consult a dentist about strategies to enhance dental care and what he or she can do to prevent future health concerns such as gum disease and infection.
Now let's take a look on this case study. An 8-year-old boy patient presented to the orthopedic department complaining of difficulty walking due to calf muscle hypertrophy. His mother described a history of frequent falls, fatigue, progressive muscular weakness, and difficulties climbing stairs that began when he was 6 years old and progressed over time. Furthermore, she reported that he must have someone hold him whenever he goes to the bathroom because he is unable to sit on a toilet on his own. He had no specific family history, but his younger brother, aged 5 years, started showing similar signs and symptoms to him. On general physical examination, abnormal waddling gait was observed, as well as physical underdevelopment, where his body weight and height is below the 3rd percentile, as well as mental retardation, difficulty in walking, getting up from a sitting position, calf hypertrophy, proximal weakness, hamstring muscle contracture, and positive gower signs were present. Electromyographic examination with interference pattern analysis shows a myopathic pattern in the right vastus lateralis confirming primary muscle disease. Based upon history, clinical examination, and previous investigations, the diagnosis of Duchenne muscular dystrophy (DMD) was confirmed. So based on the case study, we can note that the boy displays many signs and symptoms of Duchenne muscular dystrophy, which are frequent falls, fatigue, difficulty walking and climbing stairs, mental retardation, positive Gowers sign, physical underdevelopment, abnormal waddling gait, progressive muscular weakness, and also muscles contractures.
Let's continue with the effects of muscular dystrophy on occupational performance. In terms of activities of daily living, the patient faces difficulties in showering while standing due to poor muscle strength of his lower limbs. Second, toileting. He is unable to sit on the toilet on his own due to hamstring contracture. Next, dressing, especially in wearing trousers as it is hard to get up on his own. Lastly, poor functional mobility since he is having progressive muscular weakness which results in frequent falls. Let's move on to instrumental activities of daily living. The patient does not participate in helping his parents do chores that require him to walk, such as sweeping the floor or carrying the groceries due to poor ambulation. He also does not participate in cognition-based activities such as identifying money to purchase products due to mental retardation. Thirdly, rest and sleep. Due to weak breathing muscles, the patient wakes up often throughout the night and is tired or dozing during the day, causing him to breathe even more shallowly, resulting in hypoventilation and restless sleep. In terms of education, due to learning difficulties and frequent exhaustion, the patient is unable to engage in education, which has hindered his ability to write and complete schoolwork. In terms of leisure, The patient only engages in moderate leisure activities such as puzzles, board games, and computer or video games, but does not participate in heavy physical activities. Lastly, in terms of social participation, the patient engages more often with his own home or relative's home than a friend's house or in the community. Cognitive deficits such as language problems and mental retardation causing social difficulties. The physical limitations and fatigue caused by Duchenne make it difficult for the patient to keep up with others during play activities, sports, or games.
And now we are going into occupational therapy interventions for muscular dystrophy. But before that, we need to know about the roles of occupational therapy in this condition. So what OTs can help you with? The first one is, occupational therapy can help you in continuing performing your daily life activities such as feeding, grooming, showering, toileting, dressing, and writing independently as your physical ability are decreasing due to the symptoms of muscular dystrophy. The second one is, occupational therapies will help you relearn the movement and abilities of muscles that has been weakened by muscular dystrophy and slowing down the symptoms. So, after we are aware of the occupational therapy's roles, we also need to know about interventions of muscular dystrophy. First one is postural management. So this intervention is to slow down the rate of spinal curvature to improve postural deformities and to reduce the risk of contracture. The second intervention is ROM, stretching exercises, and versus O-orthosis. So the occupational therapist will provide suitable exercises for the client to improve the range of motion ROM, stretching exercises, and wear versus O-orthosis. So this intervention will prevent the muscle tightness, to keep the joints as flexible as possible, and lastly, to decrease the rate of muscle dystrophies. Now, the using of equipment. So the occupational therapist will ask the client to use a shower chairs or toileting equipment to help them to be more independent in toileting, showering, and bathing by himself. And now we are going into the mobility aids. So the occupational therapist will provide a cane, a wheelchair, or a walker for the clients to choose to help them to be more independent in their daily life. House modifications. So the occupational therapist will modify the house and put handrails along the steps. This is to make it easier for the clients to climb up by himself. And next is bathroom alterations. So this is to help the client to be more independent in using toilet by himself. Pain management. So muscular dystrophy patients may experience painful muscle cramping because of myotonia, which is delayed relaxation or sustained contraction of the muscle fibers. The first one is we need to change a mattress to a more comfortable one, and this is for the client to have a more comfortable sleep at night. Next is wheelchair sitting, where we need to put a cushion on the wheelchair because some of the patient may sit too long on the wheelchair, and this will help with the pain. Lastly, relaxation techniques and stress reductions. If the patient receives a regular relaxation techniques, this will also help to relieve the pain. Now for educational institutions. So the occupational therapist will work with educational institutions, which is school, and find ways with the educators to help the client to be able to learn independently, such as assist with writing or a use of technology. The technology will use as an alternative for handwriting. And lastly, to provide a safe environment for the client to learn comfortably. And the last intervention is peer therapy. So the occupational therapist will provide one activity that the client can participate. This is to help the client to socialize with friends with the same age as him, and also to reduce the stress and thoughts of being different from others. And I think that is all from us. Thank you and have a nice day, everyone.